Our presenter today is Dr. Bill Galanter. Many of you know Dr. Galanter, worked with him or are going to work with him on your dissertation project. And many of us faculty also collaborate with Dr. Galanter on several of our projects. It's a pleasure to have him here today. He's going to talk to us about clinical data sources within the UI health system. Let me give you a little bit of background about Dr. Galanter. He's a clinician educator, clinical informaticist, and scientist at University of Illinois, Chicago College of Medicine. He's an associate professor in the Department of Medicine. He also has appointments here with us in PSOP and also in pharmacy practice. A little bit more about his clinical role. He chairs the Medical Center's Pharmacy and Therapeutics Committee, and is also the Senior Associate Chief of Health IT. So he's our Associate Chief Health IT Officer. In terms of his research, the focus of his research is to improve medication safety using informatics strategies, including prompted patient education, data mining, and clinical decision support systems. So with that, sorry, I have to interrupt his lunch. Bill, welcome.
So thanks for Dr. Natescu and Dr. Schumacher for inviting me. This is an interesting topic for me because I do this related to multiple different things. I do another job I have is in managed care, trying to manage our contracts and the quality of the care we provide to patients in the ambulatory setting, and you need a lot of data for that. I need data for research. We need data for drug use, and I need to know about data to help other people get at data. So data. At the moment, I have no conflicts with any manufacturer of software hardware, but if you know anyone who's looking for someone, it's always good. So research, this talk is not. So I'm not actually going to talk about my research. I'm just going to talk about getting data. So this is not a research talk. And because of that, there's no insulting question or anything, because you're not going to be insulting my personal work. And I probably, I don't know if you know, Dr. Schumacher's very formal, but maybe you can ask questions in the middle of the talk too. I got to pick on everyone. I'm not going to pick on Edith though, because she's nice. So we're going to be talking about data. I love the word big data. I read somewhere big data means something that doesn't fit in Excel. I think Excel has about, I don't know, does anyone know, 100 columns wide maybe and 1 million rows? Yeah. So if it can't open Excel, then it's big data. So I don't believe in big data, but we are going to be talking about data. And the purpose of this talk is to, and it's particularly good for students, is to explain to you what is actually available here for data. So as you're thinking about projects, either for quality improvement or for research, you can actually think about whether or not you can do it with data that's available on site. A lot of the research that's done, you try to get data from Medicare, Medicaid, whatever, and that's great because a lot of times that data is outstanding. But sometimes it's expensive or difficult, and if you can find a good enough data set on site, it makes it easier. So the first issue is, where is data being generated? I'm not sure, as particularly researchers, as a clinician and as a bureaucrat, I have a sense of what's going on at the university, but I'm not sure that all the researchers or clinicians that work in a very focused area know exactly where data is generated and where care is being done. So for starters, our big clinical areas are the outpatient care center, the hospital, and the emergency department. But outside of that, there's a lot of other sources of data. Some of them are clinical. So down here, we actually have a lot of off-campus sites. And they're all in the same instance of our computer system, which is kind of nice. So from the gathering data point of view, it doesn't matter where it is. We have an FQHC, miles squared. I only put a few of the locations. There's quite a few locations for miles square. I'll call something metadata and external data. What do I mean by metadata? There are so many regulatory agencies, requirements, analysis done. We actually send our data out to companies that then play with our data and send it back to us. So believe it or not, Vizient used to be called UHC. A lot of people run a lot of queries on UHC, and they're actually running queries on a database that's sitting wherever they are on Whacker. I don't know where their data center is. And it's our data that's right, it's from our data that's right here, but they played with it and cleaned it and put a query system in that's easier. So there's data that comes back to us that's just another version of our own data. Blue Cross Blue Shield does that. We have clinical data. Eye care is an example. There's a vaccine, children's vaccine program that actually gets imported into our EMR. So that's clinical data for clinical care that wasn't provided here. So these are all just little examples. There's a lot of other things like that. The other data, obviously, pharmacoeconomics is billing. There's companies that actually bill out our services. They take what's in our computer and what the doctors say, they turn it into bills. Those bills go out, they get money back. All that information goes into systems that need to be integrated back into areas that we can ask questions about it. Okay? Even something that seems as simple as the main entity, the hospital, the ED, and the outpatient care center, lab is on a different computer system. There's an interface from lab to the hospital that's imperfect. The administrative is one way, the clinical is two way, so that causes problems. Every tiny little thing that we do often has an interface to a different system. So things like echocardiogram, endoscopy, PFT, you can just go on and on and on. Those are their own little computer systems, which are really usually sitting on a desktop, and that has to get interfaced back and forth with the main computer, and then there's errors and certain pieces of data that are not brought when that's done. So knowing the data is not so easy because there's lots of different areas where we could have problems. So I'm gonna any questions about that? It's all easy. So I'm gonna talk about some of our databases. I'm gonna say there's like original or simple databases, and then there's databases that are built from other databases. Okay. So McKesson is our financial system. It's called HealthQuest. We send that data out to a company called the Advisory Board, and then there's a cloud-based thing called Compass that allows us to query our own data. That doesn't take feeds from much of anything. It's its own data set. Okay? So you'll hear people talking about Compass. Okay? Very few people use HealthQuest to query. They go to Compass, but it's the same database. There's a database called Epic. Everyone says that we're on Cerner. We are on Cerner, but we use Epic for the financials for the ambulatory setting. So there's an Epic database. Okay. Psychiatry does their own billing. I have no idea. It could be an Excel or DBase for all I know. But psychiatry billing is its own thing. Okay, I don't know anything about it. I just know that it's not back interfaced into anything else, which is extremely problematic. So I had a research project. I had to just manually go to psychiatry, ask them to do this for me. They put it on a disk for me. We put it somewhere else because the psych billing data is not in our system. Seems crazy? That's the way it is. So this is our biggest database. It's called Cerner Millennium. So you'll hear about these big EMRs. They're different applications. So the database is called Millennium. Then there's patient care systems. For those of you who do any clinical work, PowerChart is the patient care system for most everyone. FirstNet is for the emergency department. SurgeonNet is for surgery. I don't know what it's called, AnesthesiaNet, maternity care, whatever. There's all these different user interfaces to the same database. So this is Millennium. Claims data also, so Millennium has clinical care data. Does every bit of clinical care go into Millennium? The answer is no. What types of things don't go into Millennium? A woman's pregnant, they put a transducer on the belly, okay, and they get all these heart rate tracings from the mom and from the baby and all this stuff, and it's just tons and tons and tons of paper. That does not go into our EMR real time. And that's true with a lot of things like telemetry, continuous blood pressure monitoring, art lines, things like that. Those are all continuous data that we have to cut pieces of to put them into the system. So although we are measuring the blood pressure continuously in a patient in the intensive care unit with an arterial line, that data does not go into our data repository. So not every piece of data goes into the data repository. Insurance financial information, only a little bit of that goes into our data repository, okay? Claims data, some claims go in because we have multiple areas that do claims. So psych claims don't go in. There's certain clinics that do claims separately that they don't go in. So it doesn't have everything. And then one of the important things is to know what our databases have and what our databases don't have. Because it would seem logically, as a researcher, I just think all my data should be in one database, and that should be the end of the story. But that's not actually what happens. A lot of this fragmentation or silo of data is historical. And it has to do with money, people, history. Why isn't such and such claims in that system? And the answer was, well, that system was not year 2000 compatible, and that clinic started billing in 1998, and they didn't want to go on it, so they got a different system, and blah, 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 blah. So it turns out, over time, things diverge, and you have a lot of silos and a lot of fragmented sources of data. Because the people, what are the interests of the people who are making the data? So I'm assuming you're all researchers. Is that a good assumption?
Yes.
What's your interest?
Research.
Research. What's the best type of data? All in one database. The people who are making the data, what's their job?
Sell it.
What?
Variable.
Control it.
Min, it's scoping and it's making money. Right. Sell the data, make money making the data, save money, right? Better for billing. Don't write stuff down because you might get sued later, even though it might be good for research at some point. So there is a lot of motives in the medical center for how they deal with data, and the fact that it may or may not be available and easy for research later is not high up on the priority list. So that's why things look so stupid sometimes, because that is not their interest in general. I wear multiple hats, so sometimes I'm in the I don't want to spend the money for that. We're losing money, let's not put it in. And sometimes I'm in the I can't believe they didn't put that in, what a waste, and blah, blah, blah. So different hats get different results. So to give you an idea of what's in this database, it's actually quite impressive. We've had Cerner Millennium since 1997. We have over, I don't know exactly, I knew a few years ago, more than 1.3 million patients. Probably, this I don't know how to count, so I had to guess, probably between 5 and 8 million encounters. Prescription data from 2007, inpatient med order data from 2000, lab data from 1997, text notes gradually from 2000 getting more and more and more. People are doing a lot of research with natural language processing on text data. Each year we do more than 1 million drug orders, whether they be prescriptions or orders in the hospital. Last time, this is something that I tried to count, I think it was 1.3 or 1.4 million pharmacy orders in a year. We have extremely broad payer mix. Part of that is being in Chicago, and part of that is being somewhat of a safety net public hospital. So we're just not a hospital for black people. We're just not a hospital for Latinos. We're not a hospital for white people. We're not a hospital for Asians. We're a hospital for everyone. If you look at our patient population, it's very, very impressive, the mix in patients. Since we do tertiary care, we get a lot of rich people that come in. If you need a liver transplant, you're going to go anywhere you can go to get your liver transplant. And if you're rich, it's okay. If you're poor, hopefully it's okay. So we get a lot of wealthy people that come here for tertiary care. We get a lot of very poor people that don't have insurance. We have a lot of middle class, lower middle class. The socioeconomics at our hospital is really good for research. It's broad. If you guys, the peanut gallery in the back, if you disagree. Am I okay so far?
Yeah.
Walton doesn't care, he's just eating. So I think that makes this a very, very nice data set.
Bill, before you move on, can I ask you a question about the totality of capture of some of this of the information? So, you talked about prescription data since 2007.
Mm-hmm.
That's just prescriptions dispensed from UIC pharmacies?
No. The dispensing data is not even in our database. That's a separate server, and you have to specifically go there and grab it, and it's not in any way connected to anything I talked about. Our dispense rate, I'm going to guess, is probably, I know for certain insurances, it's probably more into that 15, 20% of prescriptions are dispensed at U of I. I'm talking about written.
So those are prescriptions that are written?
That are written.
And then those are laboratory test results that are done in-house?
Yes.
Do you have a sense of what fraction of patients get their labs done in-house versus going somewhere?
A smallish fraction, because we're tertiary. So right now, if you look at, you say, like, who are our patients? I said there's 1.3 million unique patients. 200,000 of those are dead. That started 20 years ago. So what are our actual patients? So there's different definitions of that. So if I look at something like the patient's been seen at our medical center in the last 2 years, okay, that's probably around 150,000 people, okay? Of those 150,000, probably 60 or 70,000 get primary care here. So for instance, our ophthalmology is a very good department and they're very busy and large. So our ophthalmology department serves diabetics from all over the city. They don't draw labs unless they're doing a surgery. So a lot of these patients do not have much lab data. And then their pharmacy data is bad, usually because the clinicians that are seeing them are not that interested in doing meds reconciliation. And they might, the ophthalmologist, if they're getting the med history, maybe they just want to know if they're on insulin or aspirin for bleeding for procedures. The patients who get primary care here, almost 95% of their stuff that's elective is done here, but they also go to emergency departments and other hospitals. So there's a lot of missing data overall. And you have to decide, do I want to look at the patients that get their primary care here that have a very rich data set, or do I want to look at patients, is my question related to the non-primary care, where it's going to be a very shallow data set. So this is something that's being used a lot. This is called our Enterprise Data Warehouse, EDW, and it's a Cerner product. It's called Power Insight. Okay, everything's power in Cerner. Okay, or net. It could have been called Power Insight Net. A lot of Millennium goes into the Enterprise Data Warehouse. People think it's the whole Millennium. There's a copy that goes right into this database. That is not true, because there's a lot of metadata. So I'm not sure I'm using metadata correctly, but I do a lot of drug. What I'm interested in is that complicated time where the clinician decides to order a drug. It might get ordered. The nurse might or might not give it. The pharmacy might change it. So if you look at a drug order, there's actually 8 times associated with that drug order. And if you look at the number of people involved, it could be massive. The nurse has to validate. So I order a drug. Okay, and that might be all that's in the Enterprise Data Warehouse, but in reality, the name of the pharmacist who validated it and the time is going to be actually in the database. The nurse that gave it will be in the database. If a pharmacist reviewed it, it will be in the database. So there's lots of detail, which I'm kind of calling it's data, but it's metadata about the main event, which is I ordered a drug. And a lot of that detail is not in the Enterprise Data Warehouse. So if you ask very kind of broad questions, it's there. So a typical thing I might ask is, what percentage of the women seen in last year at our medical center had a mammogram at our medical center? That's going to be in the Enterprise Data Warehouse. Okay? If I want to know if the woman refused the mammogram, that's in a note, and that text doesn't go into the data warehouse. If I want to know if a woman got a mammogram somewhere else and told their doctor they got it somewhere else, even if the doctor did a very good job and said they got a mammogram somewhere else, I don't know that. So the EDW is good for many, many questions, and it's a great database, but it doesn't have every single thing that's in. And people have this idea that it's a mere copy of our clinical database, and it is not. And then it's actually, the amount of claims data in it is improved. It actually has more claims data than the clinical database. The query method, you can always, it's the Oracle database. Like every other one, you can use SQL, and many people know SQL. Todd does. I don't. Edith, you're an expert at SQL, right? No. So you can always use SQL, and the real data jocks who know what they're doing, they like doing everything in SQL because it's a very efficient, fast language, but it's not easy to learn. So then they have something called business objects, which I'm going to show you, which is basically visual SQL for idiots. And that's what I use. And you'll see what I mean in a second. The research data warehouse is very similar to the enterprise data warehouse, and we have a little bit of a confusion at our institution. We have these 2 warehouses. One is supposedly for research only, and one is supposedly for operation only, and it turns out some people use the research data warehouse for operations, and some people use the operation data warehouse for research, and a lot of it has to do with how do you get the data. The research data warehouse, I can't go grab it myself. I have to write a request, I have to pay them, then they get it for me, and I don't like it. I have to go back to them. It's not great. It's not 100% true. There's some people that have been given the right to query on their own, but it's not uniformly available. Okay? The enterprise data warehouse, you can only get data if you know how to get it. You can ask a request, it'll be really slow to get it. If you don't have money and you're at the bottom of the line. But if you know how to use it and you have access, you can get your own data. So that's the bright side of it. So here's my example. This could be totally realistic. So Dr. Walton, I'm in clinic. He calls me and says, I know you're trying to save lives, all that stuff, but I'm in the middle of running a grant and I need to know something. He doesn't really care that he's interrupting my clinic and my patients because he's a PhD type. So he wants to know how many patients are in the cardiology clinic have type 2 diabetes. So I tell him what I think about him. And then after that, I say, I'd be very happy to help you. And he tells me he doesn't have IRB approval because this is a pre-grant counting exercise. So I take note of that and make sure that I'm not going to see any PHI or save any PHI. This is business objects, okay? And the idea is there's results that you put in and there's filters that you put in that include logic. And then these are the objects, which are basically healthcare associated entities, and they're squares or triangles, wherever, they're objects. And you move the objects in and out of the queries, out of the results and queries. Sounds really simple, and it's not, but it's more simple than SQL. Okay? So I know that he wanted to know how many patients in cardiology clinic have diabetes type 2. So I pull in diabetes, the location and the diagnosis code, and I realize that nothing's going to happen there because there's no logic to it. So I first say, well, how am I going to find the patients? I need to tell the computer, when am I looking? So that's actually a filter. I don't want to look at all time. I want to look at subset of time. So I drop my discharge date into filter. If I put my discharge date up here, it's a piece of data. So I can put discharge date up here and just drop it down here, or I could just take it from here as an object and make it a filter. This is, I think, relatively simple way to build queries compared to writing a bunch of code. I realize if I look at every registration location, then I'm going to have this giant Excel file, and then I'm going to have to cut out just the cardiology clinics. So why don't I just say I only want cardiology? So that's a filter. So I put cardiology there. When you drop something into filter, it's a multi-and statement. It automatically assumes and. If I want to do an or, there's a way to actually pull over an or. So I could do an or and multiple ands or whatever. So it still uses kind of computer logic, but it's visual. Okay. Now, I only want heart failure. So if I don't filter it, I'm going to get every diagnosis of every patient seen. So I'm just going to put heart failure in. And probably what happened was I went back to Dr. Walton and said, well, I need the heart failure codes. And he probably said, how do I know? I'm an economist. So I had to find my own heart failure codes. So I put my heart failure codes in. Now it looks like I can say what dates I want, what clinic I want, and what codes I'm interested in. So I give it a go. Okay? And because I didn't ask for account number, medical record number, name, social security number, I didn't see them. So this is okay with the IRB. So then I have my answer. And then he tells me, of course I was just talking about Medicare. Are you an idiot? No one cares about anything. I'm never going to grant if I don't do Medicare. So now I say, you jerk, whatever. Okay. But I saved my report, which is okay because my report didn't contain any PHI. And it was as easy as looking up age, taking it, moving it over here, picking something called greater than or equal to, and then writing 65. Pretty easy. Right? So that's business objects. So a couple of things about business objects. The institution is still struggling with who has the right to what data and what access to what software. So I would just say it's a crapshoot who gets access to business objects. I'm just going to admit that. Can someone, yes, sir?
I didn't want to interrupt though.
Oh, please do.
Right away. So, like, is there some kind of hierarchy where it's clinical faculty, tenure track faculty, students, fellows, like, or you're just saying they roll the dice every time there's an application, it doesn't matter, like.
It's meant to be an operational database. So people that have access to it that also do research, they can do research with it if the IRB says it's okay. So how did I get access to it? For operational reasons. Do I do research on it? Of course. But I have IRB approval, and it logs my use. Because it's sitting on top of Oracle, and Oracle saves who's touching what when.
So you have like a blanket IRB approval to query it?
No. No.
So
It's like any other IRB approval. It's for
so
specific
take,
things.
For instance, that hypothetical example that you gave of Dr. Walton, saying, could you tell me how many?
Right.
So presumably there's no IRB for that.
Right. That's a pre-IRB counting. I made my example.
Right, but Dr. Walton couldn't do that, but you had access because you have some kind of blanket IRB approval?
No. I have access because I have access. So that's really what needs to be. I have access because I'm the associate CHIO and the medical director of the group. That's how I have access.
So if Dr. Walton had access, he could do it himself too under prepared.
I don't know if he's smart enough. But theoretically, yes, Min. Theoretically, yes. So here's what happens. So let's say your department, PSOP, they hire they have a graduate student who's good with computers, and then they go to IS and say, we want our graduate student to have access to help us with our research, et cetera. They probably would say, okay. And they'll say, but that you need IRB approval for anything that you're going to do. Okay? If it's for operations, they absolutely will say okay. So if Andy Donnelly down in the pharmacy says, I want someone with access to EDW because we do need to get operational data for the pharmacy, then they will 100% say okay. So a lot of departments are having like designees from each department getting access to help. But I think I'll just say that it's a little confusing right now who gets access and why.
Who grants the access?
What?
Who grants?
IS.
Are they using this for QI?
This is mainly used for operations and QI. I actually mainly use it for QI. I use it some for research, but I mainly use it for QI. So I think this is something the institution is struggling with right now. We have a new head of the IRB. There's a lot of emphasis on security, and we're struggling with what is the appropriate way to control access to data in a safe way, but also a way that allows people to do their research. For operations, there's no restriction. If I'm the head of the nurse if I'm the head of the ICU nursing, if I'm the head nurse of the ICU, and I said I need access because I want to get data on utilization, that person will get it in a second. So for operational purposes, they give the access to anyone who has any type of leadership role that would need data.
So for example, if I run the anticoagulation clinic, I may be able to get access to this kind of data.
But only the real clinicians that actually run. If you're like a bureaucratic head of the clinic, maybe not. But if you were like one of the real clinicians that ran the clinic, you might be able to get access.
Okay, now, let's see.
So it sounds like our graduate students should talk to Edith.
How about if you run the
Do you
first
think Edith is smart enough to run this?
What kind of question is that?
Maybe not. I'd be smart to whoever's nice to them.
Actually, the smart thing is not to learn this, because once you learn it, I get a million requests for data from people all the time. So we have a problem here because we have this wonderful tool. Yes, absolutely, because you always interrupt me. So we have this wonderful tool. But we haven't actually figured out how to use the tool correctly. Security is not trivial. I could go in there in a second and find out every single person has HIV. Could they know that I did it? Yeah. Oracle saves all that. You can see Galanter ran a query. It went to this cell. He pulled it back. I couldn't hide that I did it, but are we running around auditing everything that every person is doing all the time? So security is a very, very significant thing. So this is something I think as an institution we're struggling with right now.
So Bill, I want to just ask you a question, and maybe I missed it, but there's the data warehouse which charges money and is really slow and all of this. And then there's this route
Mhm.
with business objects. What are the data, and I understand business objects is for operational purposes and the data warehouse is technically, or no, that's not right, for research? I'm trying
You
to.
can do whatever you want with it. It's the way the institution sees it.
Okay.
Business objects is a completely legitimate way to get research data.
Why do we have the data warehouse? They seem duplicative.
They are duplicative. So it's historical. Okay, why do we have a research data warehouse? Where'd that money come from?
CTSA,
CTSA. Why do we have an enterprise data warehouse? Where did that money come from? Hospital operation budget.
Okay.
And the
well,
research people said, so we had at a time in the past, maybe, what CTSA are we on? Third one?
second as far as I know.
Second? Third.
Okay.
So that would be, it's 4 years?
I don't know.
So probably 10 years ago, or whatever, 8 years ago, 7 years ago, someone had this idea, let's make one data warehouse, and research could use it, and operations could use it. And the research people probably said, this won't do for us. And the operations people said, this won't do for us. And the operations people said, we have a lot of money for a warehouse. And the research people said, we have a big grant. So the research people made their own warehouse, and the operations people made their own warehouse.
Okay, thank you.
So I can't say for sure, but it might be as simple as that. But it's like any other data that gets siloed. Everything is this. What if the EDW was ordered from Cerner before we got the CTSA grant? So they ordered it, they were buying it, it was being installed, then we get the grant, research people look at this and say, this won't work. So there's a lot of complication. Yes, ma'am?
Do the two systems handle protected information the same, or does the
No.
research warehouse handle it differently?
Well, the research warehouse, their model is people don't touch it other than our staff, which you could do with this. But then that would be these databases, modern databases, they track what people are doing inside of them. So there's audit trails. The issue is, who do you give access? I cannot go into the research data warehouse. If I learn their language, I still can't go in there. I can't get my own data. I have to pay someone else to get data. And if it doesn't look good, then I have to go back to them and they give it another try. So me as a researcher, I found when I can find my own data, validate myself, go back and go back and go back, I might get the data I want in 2 weeks. When I have to work with a professional programmer that doesn't understand anything about healthcare data, and they have to build it, run it, I have to look at it, validate, go back to them, give new criteria, it might take months and months. So I find this to be way easier way for me to get data for research. So it's very unsatisfying. I'm just trying to tell you the truth, that we're very confused right now about what exactly we're going to do. But people do get data out of this enterprise data warehouse, especially if they collaborate with me. Now, there are other people that get research data out of this database. But it's not so easy as, hi, I'm a grad student, I work with Dr. Lee, I'd like to learn this language, which, by the way, I didn't take a class. I just have been teaching myself. I'm not great at it, but this is the kind of business objects kind of thing. If you know a little bit about computers, you can teach yourself business objects. So you say, I'm getting a PhD. I'm doing research for the next 3 years. I'm happy to take the course. Tell me what to do. I want to get access. We're working on our IRB. I'm not sure what they're going to say. I don't know. I don't always know why they say yes or no about different things. Okay. We have time, so other questions. Yes, ma'am.
Do you know if other hospitals are having similar problems, or is it just kind of everybody keeps it themselves?
Yes, every model is different. So I can tell you, I have collaborators at other hospitals that can run. I never try to pull data out of, by the way, all these, the Millennium, it has multiple copies. Because if, let's say, the hospital burned down, we're responsible for having that data. Our data's in the basement. If we had a flood, we actually have 2 copies that have the identical data that are in different locations in Chicago in case there's a giant power outage, fire, flood. We have like 5 domains. So I never touch our production domain if I don't have to get data, particularly not for research. Because all the research I do, it's retrospective. So I don't want to be whacking on the production domain at the same time the clinicians are trying to take care of patients for research. I do whack at the production domain for operational things where the delay in the copying between the databases is not working for me or for other reasons. It's faster, actually. I know people, colleagues of mine that I do collaboration with, they whack at their production domain for research like, boom. You know, they don't care. So I think there's places that are a lot looser than us. Northwestern has one data warehouse, to my knowledge, and you have to pay for it. So they basically, whether it's operations, research, whatever, it's the same as our research data warehouse. You pay money, you put a request in, you get data whenever they can get it to you. If there's a problem, you modify your request, they get data whenever they can get it to you. So they don't have this. So it depends.
How is that project going with the shared data across the hospital system?
Oh, that's so interesting. Is that why you're asking about this, Dr. Walton? You want me to jump to the next slide then?
Sure.
Okay, so that's the next slide. Any more questions? So this is a project that I've been working on. Did you do that on purpose so I can segue well? Okay. It changed names. Guess what it's called now? What'll be your guess? So, HealthLink, yeah. So this is a project that I've been working on literally for like 15 years. Is basically to share data across institutions for research. It's kind of like a precursor to the Capricorn project, if you know what that is. And it's had little bits of funding at different times, and it's gone through different names because whenever you get funding, they get that name, and then you lose the funding, you have to pick another name. So this is the third. It used to be called Chicago Health Atlas, and then it was called something else, and now it's called HealthLink. Okay, really nice professional website, but it's Northwestern, so you know. Okay, so what it is actually a database. And there's the founding organizations, actually originally it was Northwestern, Stroger, and U of I. Okay, and we actually had a paper published with just those three institutions that Dr. Walton helped me significantly on. And then U of C, Rush, and Loyola got added. So these are 6 academic hospitals. There's a whole bunch of federally qualified health centers. Our system is Miles Square, and then the system associated with Northwestern is the Alliance of Chicago Community Health Centers. So there's a lot of community health centers. The first set of data was 2006 to 2016, when I invented my time. So it's 2006 to 2016. From 6 to 12, we only had adults. And then we did a big IRB push to change slightly the data in it and to actually include children. So we will have children from 2012 to 2016. Okay? Patients are connected across institutions and de-identified. Okay, so that's a little complicated. I just want to explain it. It's cool and it's worked. It's different. What we do is we take information about the patient. First name, last name, gender, date of birth, social security number. And we put those all together. It's called concatenation. We just make a big array of digits, a alphanumeric array. And then there's actually US certified encryption algorithms that take an array of, a linear array of elements and turns it into a 35-digit array. It is non-back hackable. Once you have that 35-digit array, you cannot go back and find out who you got it from. So what we do is each institution makes a 35-digit array, okay? And what we do is we do it based on as much data as we can. First name, last name, if we get social security number, great. If we know the sex, great, okay? And then we do what's called probabilistic matching. How likely is it that it's the same person? Okay? So if the patient has a really, really weird name, any basketball fans out there? Meta World Peace? There's a basketball player, Meta World Peace. So if I only had Meta World Peace and I knew that it was a man, I might be able to match that patient at all times through all healthcare because it's very unlikely that anyone has a remotely similar name as Meta World Peace. Okay? If my name was Bob Smith and all I had was Bob Smith man, I'd probably say I'm not too confident with my ability to match to another Bob Smith man. So it's called probabilistic matching. Way too smart for me. We had some excellent kind of mathematical informaticists work on this. And we developed this algorithm that very, very accurately matches names without losing too many. Because this is research, the fact that you can't match people is not a big deal because you're not providing care to them. So Dr. Lee gets admitted, and I need to know very quickly what's going on with him because he gets his care at Rush, but they won't give me Dr. Lee's information because he has no middle name. It's just Todd Lee, but at Rush, someone made a mistake and said Todd A. Lee, and even though it's the same birth date, sex, first name, last name, I can't 100% prove that it's the same, so I can't get that data. But for research, it's okay if you can get 99.9% of the patients in your cohort and throw out the 0.1% that you don't know about. So it's very easy for research purposes to do this in a reasonable way. Now, all these things go to Northwestern, and they all get matched up by the 35-digit code. So although I don't know who it is, I know it's the same person. So I cease to know that it's Dr. Lee anymore, but I know that the patient who went to the ER with the laceration 2 years ago was the same person as the one I'm seeing now in my ER, even though I don't know it's Dr. Lee. Does that make sense? So this is great for research, which means I can follow the patients around the city, at least at those institutions, and see what happens to them. Okay? We have more than 1 million patients. The database sits at Northwestern. We have an IRB at every institution. Our IRB is being amended. We're going to the 2012-2016 with children, but we still have a running IRB on the other one. And the beauty of it is the whole purpose is to do research, which means it's free. So for the founding sites that maintain IRBs, and I'm the site director here, if someone wants to do research on this data, they just ask me, I give them a form, all the sites vote on it. I'll get into, there are reasons that institutions might not want, let's say that we keep track of the sites. Let's say that there was a site in the city that they didn't treat many black people, Latinos, or poor people. Just hypothetically, it's probably not true. Let's say that there was a site like that, and I did the research study saying, are there any hospitals that see way less poor people, black people, and Latinos than other hospitals? The site director at that site might say, that doesn't sound like very good research to me. It looks like you're just trying to make fun of me. So we do require approval at all the sites, but generally we approve everything. But our job is not to make sites look bad. That's the reason why we don't let everything go through. Once our IRB is approved, which I'm hoping in the next month or two, we still can do research on 2006 to 2012, but we want all of it. You fill out a form. What's your question? What do you plan to do? Do you have funding? Whatever. This is the web page. I was very lucky. The last paper was one of my papers. It shows all the studies that have been published. We're not doing a great job at U of I. The majority of the publications are coming out of Northwestern. And really, everyone has equal access to the data. So I want to promote use of this data to our institution. So Northwestern's getting most of the benefit. We're getting a little bit of the benefit. U of C's not doing too much. Loyola's not doing too much. Okay? It's meant to be for everyone. We have a relationship with the city. When the city wants data, we're happy to give it to the city. And we've done some stuff with them. This is a study, so a colleague of mine at Northwestern, they wanted to know what parts of the city are likely to have underdiagnosed diabetic retinopathy. So a lot this data is always cool when you show pictures of the geography. So this is a picture of where underdiagnosed diabetic retinopathy is likely. This is our study. This is the ratio of what PCED means is primary care in the ED, sorry. Primary care in the ED. This means diagnoses that should have been taken care of in a clinic that are being seen in the ED. Stub my toe, a cold. I don't want to get into more of the medical things, but basic things. Mild headache. And we compared that to things that are absolutely unpreventable. Heart attack, threatened abortion, sepsis, blah, blah, blah. Don't want to get into the details of the paper. And then we could look at where was it in the city that a lot of that was going on. And one of the things we found, there's a lot of it over here. If anyone knows the city, these are not wealthy neighborhoods. Okay? So these are typical geographic information system studies on a very nice database. And one of the nice things about this database is it's got a good thing and a bad thing. The good thing is Medicare, Medicaid, no pay. It has nothing to do with insurance. So if you do these studies with just Medicaid data, just Medicare data, just Blue Cross Blue Shield data, that's a limitation. What's imperfect about this? It's only the data available at all the institutions. So it's not a perfect data set, but for many things it's good enough. I mean, the number of diabetic patients is massive. The number of people with COPD, asthma, massive. Yes, ma'am?
Have you, with the geographic studies that you've done, have you ever overlaid that with the areas primarily served by institutions and not a part of the consortium?
Yes.
So do you see that there's a...
You can actually subtract out for that if you're looking at things that are numerical. What we tend to do is to try to do ratios so that it becomes not as important. But it's like an overall catchment. We have the catchment of every institution and then the overall catchment of the institutions. And that completely biases what you can look at. But when you look at ratios, so if you look at those six institutions, maybe in McHenry County, they only account for 15% of the patients, but I still can look at 15% of the patients in McHenry County. So it's clearly a problem with the database, but it can be overcome for most questions. Any other questions? Yes, ma'am?
You said the Northwestern's been using a lot. You've been using it, some of them are not.
I can't hear you.
How do you actually access it?
This database? You fill out a form. I give it to the group. Okay, we vote on it and say, is this a reasonable project to do? The answer is yes. You send a graduate student over to the Northwestern. It's not a web-based app. Okay, and it's not hard, but there's a little learning to do to get the data out, and you take the data. And the nice thing about it is to send those 35-digit things, I had to take PHI and encrypt it. That is human subjects research. So the overall IRB is real research, is PHI research. But anything you do is going to be exempt because you're using a previously obtained de-identified data set. So it's a trivial IRB, and you just mention our main IRB, and then it's just have the manpower, person power, to go over to Northwestern and get the data, which is not trivial, but considering that the data is free, it's not too bad. So the paper that I just showed that I published, I had a grad student at Urbana. This was his master's thesis, and he spent like 4 days here. He stayed up here for 4 days, went to Northwestern, learned how to do it, grabbed all his data, went back, did the analysis.
So are those resources at Northwestern for somebody to teach you how to do it? If you send somebody over,
yes.
They do it for
free. This has been like a very nice success of cooperation between the institutions.
What's the timeline? Let's say one of our students or one of our faculty wants to access this for a project. Can you get access within a month or 3 months, or what is? Give us a sense of how long this is.
There's no IRB. I don't have the IRB for the 2012 to 2016 with children. So if you want the whole data set, number one is we have to get the IRB approved. We're on the second cycle of it, but the way the IRB is lately, this scares the heck out of them. So the way the IRB has been lately, I don't know. But as soon as the IRB is approved, it's fast. You give the proposal, we send it to the group, we do email voting, almost everything's approved unless someone was trying to do some dirty trick to make one of the institutions look bad. And then if you've got someone, you'll be able to go over to Northwestern and meet with people, and they'll help that person get data.
So I actually had Lisa Glenn and I submitted a grant just recently, and I was going to write Capricorn into the grant. And it actually did not seem like that simple of a process.
This is not Capricorn.
Oh, okay.
Capricorn maintains identification, and it's meant for recruiting patients. This is a de-identified meant for retrospective analysis. So this is not Capricorn.
Okay.
They use some of the connections we made and ideas were in Capricorn, but this is not Capricorn.
So then the VAs are not included in this one?
The VA is not included in this.
Was this geocoded before you did the 35 digits, or how did he geocode it without addresses?
We cannot completely geocode because it's not de-identified then, so we just do it by zip tracks.
Zip track.
And actually, it's very, I don't want to get into the details. There's a really smart guy, I think he's at Tulane, Brad Malin, is an informaticist.
Yes.
You have to throw patients out based on the probability of figuring out who they are. So depending on how many people live in that zip code and what their disease is, that you can predefine who you throw out. It's the same idea when you throw people out that are 95. You know, they always go up to 85.
Yeah.
So there's actually, as part of this, it's actually quite complicated.
Believe me.
Believe me, I didn't figure it out.
I believe you.
It actually looks at diseases of that patient, how many people are in their zip code, how old they are, what their ethnicity is, and then it says, no, this patient will be too easy to figure out who they are, and it throws them out of the data set. It's very rare, but it does.
Sure.
MetaWorld Peace is also known as Ron test, so that's a very
Run our test.
MetaWorld Peace.
I'm kidding.
That's it. He wouldn't work very well in your
No,
house.
I wouldn't. Yes, ma'am?
Can you talk a little bit about the drug information in the database? It's all from EMR. So
I don't know what time you guys, I'm not busy, so I'll talk. I don't know what the official time is for things.
We have to go to a faculty meeting.
Oh, you guys do. But they're okay?
Yeah, they're okay.
Okay.
Someone may come in here, that's the
Oh, that's fine. So what about it?
So it's all prescribed. Are there any claims in it, or is it
Yeah.
all just prescription?
Yes, but the claims are rare. So we have claims for it gets, again, getting data back from the outside. We have claims for the patient that we have some financial responsibility for them. So we have claims for Blue Cross Blue Shield, HMO Illinois, Blue Advantage, Blue Precision, Blue Focus, and then Blue Cross Blue Shield, Community, FHP, Medicaid. We have claims data for them.
Do you have an idea of the percentage just off the top?
Thank you so much.
Sure. It's low, it's probably 10%, 5%. And then we only have fill data for the patients who fill at UI. There's actually fill data in the computer. Do you guys know what SureScripts is? SureScripts, it's illegal to use that data. So a friend of mine at Harvard, he's doing a project and they said, no, you can't do it. So you can actually go into the computer and you can see if a medicine was filled, but you can't use that for research and you can't make a copy of it. That is proprietary data. Sounds crazy. I just did an adherence literacy project where we wanted to go see if patients filled, and we couldn't do it because SureScripts has the rights of that data. Mm-hmm. Yes?
Are there interest in people like other big systems, like the advocate system or like the
Say again?
Is there any, do you have it, are you guys doing anything to kind of see like the other, some of the other?
Well, I think Capricorn has North Shore.
Okay.
This group, HealthLink, we're open to anyone who's willing to do it, but there is a cost to doing it. The initial IRB is a pain in the butt. So usually institutions that don't care that much about research, it's hard to get someone very interested. The application that does all this stuff, that grabs all that stuff and makes different iterations of the digits based on what's available in the chart and all that, it was actually done. Some of the graduate students in computer engineering at UIC helped write that application. And it's a Java, and it's an applet, which means you could just drop it behind a firewall. So we can give it to any institution. It's not that big. I can email it to them and say, just put this behind your firewall, run it, and drop your data into it, and it'll produce the encrypted data. And that's free. So the issue is to get things through IRBs is not easy nowadays. And if you don't care about getting papers out and things like that, it's not worth it.
You're working with the central IRB on?
What?
You considered, I don't know if it would work in this circumstance, but getting approval via central.
We haven't. I mean, at the time we started doing this, there was no such thing as a central IRB, but we haven't done that.
Yeah, because that's, I mean, I have a friend who works in informatics at present, and they're not set up for a research institute.
I think the IRBs are going to say no. I mean, the government is about to say, there's a new final rule. The government is about to say you have to do a central. AHRQ is soon to say you have to do a central because of the administrative costs associated with multiple IRBs. It's wasting tax dollars. I agree with that. But they haven't said it yet, so I'm on an AHRQ grant that's multi-site, and every site said no. So I think this one that seems really scary, it's actually not scary at all because once you do that encryption, which is behind the firewall, it's really safe. Because that is actually a government certified unbreakable encryption. So it seems scary, but it's not scary. We have to sell them on that. But I suspect the IRBs will not do a central IRB on something like this unless they have to. If we got a grant and the funding agency said you have to do a central IRB, then they do. All right.
Can I ask one more question?
No.
What about the clinics affiliated with the College of Dentistry? So all of oral health stuff, not in there? Not in the power corporate?
No, there's never been a consolidation of any of the dental data into Millennium. And again, I think it's all related to money and timing.
Okay.
I'm sure at the time that dentistry, probably the time that dentistry were buying their systems didn't match with the time that the hospital was buying systems, and they had different needs, so they did different systems, and then they're all going to be off sequence for forever.
Okay.
So the answer is no. Could you do it? Of course. I mean, when you do research, you can take, like I have to take psychiatry claims, it's not a system. So could I take data from dentistry and merge it with, of course.
They just sent me some stuff, actually. They were very nice.
Yeah.
So.
But they're not, it's not inside, you'd have to do, external manual merge.
So if you want to look at like dental visits and the patient's medical diagnoses, you would have to merge that.
Right. But I think it would be relatively easy.
Yes.
It's a small data set.
Right.
One of the problems of merging this, if you're a researcher,
Yes.
and I'm sure you know that one of the problems of merging this kind of data is if dentistry is on a different account number than the hospital, then you're going to lose data when you have to do one of these artificial estimate probabilistic merges. You'll lose a certain degree of data.
Yeah. Thank you.